Hi, everybody. Welcome to Africa's webinar for the World PICU Awareness Week. We're very excited to have been able to share this time with you. My name is Brenda Morrow. I am a physiotherapist. I'm working in Cape Town, South Africa. And I am also very pleased to say that I have recently been appointed as President-elect for the World Federation of Pediatric Intensive and Critical Care Societies. So I've got a few hats, but basically I'm proudly African and a proudly critical care professional and researcher. I'm very honored to be chairing this session, and I would really like to thank all of our presenters for really a very interesting and very broad perspective from different regions in Africa. I would really like to invite each of them to introduce themselves before we go on to addressing some of the questions. So I'm just going to take people as I see them on the Zoom. And the first is Professor Mignon McCulloch. If you can introduce yourself.
Hi there, everybody. So I'm also a proud South African, and I wear two hats. I'm a pediatric nephrologist, and I really believe in trying to make kidney disease easy. And I'm also an intensivist, and really proud to be part of this team, and very excited to have WIFPICS in South Africa in Cape Town next year. So thank you for that.
And next up is Dr. John Adebia-Pierre from Ghana.
Hi, I'm John Adebia-Pierre. I'm a pediatric critical care specialist. I'm the founding head of the Pediatric Intensive Care Unit in Ghana, the first pediatric intensive care unit that we established in Ghana. This is in 2015. I'm happy to be part of this team, and I'm looking forward to PICU in Africa, with PICS coming to Africa.
Thank you, John. And the next one is Charlene Kilba, who is also from Ghana, a different region in Ghana, to John.
Yeah. So my name is Charlene Kilba. I'm also a pediatric intensivist, trained at the Red Cross with Brenda and Mignon and Minette and the whole team there. I'm currently in the Greater Accra region, in the capital city of Ghana, and set up the first PICU in the southern part of the country. So it's actually also the first PICU outside of a tertiary institution. We now are a tertiary institution, but initially we're not. So it also came with its own challenges, sort of a little different from John's experience, but generally I would like to, as part of the introduction, encourage all those who are trying to set up a service in their respective countries that it is doable. So you can always get in touch and we can help you.
Thank you, Charlene. Ilse Appel, Dr. Ilse Appel, who is an intensivist, recently joined our team as well. Ilse, can you introduce yourself?
Thank you, Brenda. Hi, I'm Dr. Ilse Appel. I'm a ped intensivist. I'm currently at Red Cross War Memorial Children's Hospital, and at the start of the pandemic in March 2020, I was at Tygerberg Hospital with Dr. Nur Parker. Very excited to be part of this chat. Hi.
Thank you, Ilse. Professor Minette Coetzee is next.
Thank you very much, Brenda, and also for the invitation. Just been such a great experience. My name is Minette Coetzee. I lead a team of nurses, and I'm a nurse. I feel as if the team keeps growing as it grows across the South Africa and the region, and it is a very exciting space and time. Thanks, Brenda.
Sorry, I lost connection briefly there, so I've just turned my video off for a moment. Professor Elizabeth Molyneux, we are so grateful to have your expertise and your presence here. It really is such a great honor always to see you. If you could please introduce yourself, because I won't do you sufficient justice.
Oh no, I'm very honored to be here because I'm not a pediatric intensivist. I'm an emergency wala. And I just love the way that the team here expands critical care beyond the intensive care unit. And I think it's so important that we see all ourselves as part of a team. I've spent many, many years in Malawi. Malawi is where my heart is. And I was head of department there and started the emergency department. And I know not all, but many of the wonderful people on this panel who helped us to get strength when we needed it. Thank you.
Thank you. I see Nur has joined us, Nur Parker, who is an intensivist from Tygerberg Hospital in Cape Town. Nur, would you like to introduce yourself quickly? Is Nur... Nur doesn't seem to be connecting, but that's Nur Parker is a close colleague in the Western Cape who trained at Red Cross and is I think he's heading the Tygerberg PICU, am I correct? I think I am. Luca, would you like to introduce yourself as well as one of the chairs of this initiative?
Hi, this is Luca from Rome, Italy. So I'm the foreigner of this panel. And sorry, I don't know why the camera is not working, because just I want to hide my situation. No, I'm joking. Today is a rainy day in Rome, so you don't lose much as a view. And no, I mean, I was in Africa sometimes doing some mission, either in Ghana, in Togo, and so working in the, not in hospital, but in the country, and was really a great experience for me. Instead, I was in South Africa for tourism, and I enjoy very much either working and either be a tourist there. So, and I'm really impressed about the webinar today, because I remind the same feelings I had when I was in Africa, either working or as tourist. So a big emotional participation, a big effort, and so a nice webinar.
Thank you very much, Luca. I think the warm heart of Africa spreads across the continent, and I'm hoping that we can share that with everyone, and also for WIFPIX 22, that people will join us with that. So we're going to move on to the Q&A, but first I just want to comment that at the height of the presentations, we had 112 people listening and attending this webinar, which is absolutely fantastic. And that's people from all over the world that have joined us to listen to our experiences, which is really exciting. And I just really think it shows the potential and the strength that we have in pediatric critical care within Africa. So we've had some questions that have already been answered by our super keen panelists, but we can go back to some of those for extended discussion. But there are some new questions that have come up. The first that I'm just addressing from Zaf is directed at Charlene. For Charlene, as a young intensivist returning to Ghana, what did you find most challenging as you went ahead to set up your own unit? And what advice would you give to other colleagues returning to their countries from better developed training areas and programs to overcome the challenges and frustrations and continue to progress?
Well, the first piece of advice is not to give up. The challenges are definitely enormous, but do not give up. Take it one day at a time, one problem at a time, and work at it. For me, even finding a space to start the PICU was a challenge. Because it was, I mean, the initial thinking was that we could just have 1 or 2 beds in the adult ICU and admit children in there. And it wasn't working properly. And it was a lot of meetings and discussions. And then finally, we were allocated our own space. But space, equipment, human resource, because this is this was a completely new aspect of healthcare that we were introducing. So finding nurses, finding people who were even interested in working there, because everyone sort of runs away from PICU because they imagine long, horrible hours, and no one wants to be in there. So it took a lot of encouraging and advocacy to get people interested and to commit to it. And I must say that the hospital management was very supportive when they did decide to give us a space. We're trying to get staff. We had to start with 2 critical care nurses and then 10 just registered nurses, diploma nurses, fresh out of nursing training who had absolutely no work experience yet. So you can imagine how challenging the first few months were. Apart from nursing resource challenges, even with medical doctors was a challenge. So for several months, it was just me and the nurses. And they worked hard. I must commend them for that. Working hard, trying to learn about new equipment that they were having to work with, ventilators, monitors, learning new skills on the job. The 2 critical care nurses we had did not have a lot of pediatric experience, but they did their best, learned on the job. We trained together and we tried to make the team work. So I think the support from the hospital management was key, like giving us a space, advocating for staff to be posted to the hospital for the pediatric intensive care unit. And it took a lot of hours from me as well, endless hours being called and still being called at all times of the night, any day. There's no day off. there's no day off, but it gets better as the people you work with improve their skills and their capacity. Then you also get to have a bit more time for yourself. I was talking about the difference between myself and Adebi because John was lucky in that aspect that his PICU started in a training institution. So he had residents, pediatric residents to work with, which I unfortunately didn't have. So for me, it also opened my eyes to the importance of nursing care because the nurses had to fill in that gap and had to be able to call me and tell me what was going wrong for us to be able to work through when they were having challenges at night. So once we have committed people with adequate training, it might not be the best, but we can still make it work somewhat. And that is where we are. We're still having the same challenges of inadequate staffing, inadequate medical officers, and still day to day trying to make it work.
Thanks very much, Charlene. And you really are, you're an inspiration to everyone, as is everybody on this call. So it's wonderful to hear your experiences. The related question, which I think I'm going to address initially to John, what were some strategies in the context of a country where there were no pediatric intensive care units? What were your strategies to actually sway the decision makers, the ministries, the governments, in terms of prioritizing pediatric critical care? What strategies did you use? Maybe if John could address that.
Yeah, key among the strategies is providing the hospital with information, data, showing the direction the hospital is going when it comes to managing critically ill patients. So in my presentation, I mentioned how we set up a pediatric emergency unit. That was in the early 2000s. We're able to reduce mortality, show the hospital that setting up an emergency unit actually reduced mortality by half. But we got to a point where it stagnated. And then we use that same data, follow-up data, to show them that these children are dying because of these critical organ failure. I mean, specific to managing patients who are critically ill. We looked at our resources. Yes, the hospital had an adult ICU. So the conversation began, we showed them the adult ICU, what was going on and the number of kids that were making it into the adult ICU. again, it was difficult. Sometimes it looks like you are fighting the adult unit, but it's just data you are using to support what you are doing. So we're able to show the hospital that, yes, this is the proportion of patients, pediatric patients who admit, but this is the proportion of pediatric patients going to the adult ICU. This is their outcome, and we can also impact on that. So that is one of them. The second one was also to, aside this data, the second one was also the difficult part to convince colleagues and your own your own colleagues, the fact that what you are going to set up is going to be beneficial to everybody, not only your personal ambition. So moving along that line, I was able to convince some of the key decision makers, and I guess you need to focus on the key decision makers to be able to do that. And the second one is to build a team. The third one was to build a team, and the team was made up of with doctors and critical care nurses. And I never meant to move without critical care nurses. And actually, we worked something out with Minette and her team, and we were able to put up, she put up with me and offered to train some pediatric critical care nurses. And fortunately, this is what has been helping us. And back home, again, there are other things like unavailable. We didn't have any equipment. So what we initially started for about 1.5 years, we did part of that in the adult ICU. We migrated to parasiting the emergency unit and managing cases without equipment. So more or less still providing critical care services without mechanical ventilation and so on. We improvised, and later on we allocated a room when they saw what we were doing actually was benefiting the hospital first, and then also our pediatric population. So in terms of justifying what we're doing, at least we're on the right footing, and gradually we began filling the space. The concern about funding, paying for the cost in ICU, we pushed and set up a fund, a Little Steps Fund, to help pay for some of the cost of staying in ICU, but specifically medication, not ICU accommodation, to ensure that patients' outcomes were improving. And with that, the hospital finally and eventually everybody bought into the idea. Thank you.
Thanks, John. I think I'd like to address Minette now and relate the same question to her. So Minette, how do you prioritize training for nurses in pediatric critical care when there is such a need for training in so many other areas of health? How did you go about strategically managing that process and advocating for your training program?
Thank you, Brenda, and thank you, John. Really, the first answer that comes to mind for that question, Brenda, is the question I asked one of the nurses when I said, "What's most important?" She said, "Partnering." The way that I'm a really good follower. I'm also a really good. I love watching where people are moving and moving with them. So I first found Liz, and I watched the strategy of emergency, and we've just heard John describe that first: establish an emergency unit, gather the data, now look at PICU, and then I found John. John introduced me to all the most important stakeholders when you're working with any kind of workforce planning and training. And training and workforce planning absolutely have to go hand in hand. The first really successful program was the Malawian program. And from the beginning, it was the sense of the Ministry of Health was enrolled. Liz, I don't know, by Angela Chimwaza, enroll the Ministry of Health, enroll the head of nursing, enroll. John introduced a new stakeholder in his setup, enroll also the Medical Association, the Association of Pediatricians. And in that, we followed where the energy is, and energy, commitment, passion. because this is teamwork. I mean, a nurse comes from a country, calls from a country and says, I come from a country, there's no PICU and I'd love to be PICU trained. Going back, he or she really is on their own. For us, it's been following where people are moving with passion and helping to gather the resources, work alongside.
Thank you, Minette. So I've heard this is sort of nuts and bolts from quite a few people. There's a lovely question from Zaf that's just popped up. So I want to change tack completely. And I think I'm going to address this to Liz with, I think, the greatest duration of experience of everyone here. So Zaf says that Charlene's already noted that the hours are long and hard, and it can get very lonely working in this field for healthcare workers. And so Zaf is asking how colleagues in Africa look after themselves from a well-being point of view. And given that Liz looks so amazingly well, and I would really like to hear from you how you manage that.
Well, I think, as Charlene was saying, and Minette, it's the team that you build with you that supports you. And I think just as much as you give them support, they give support to you. I think also you should be happy with collaborations. You know, enjoy your colleagues who want to help you. We're not territorial. We shouldn't be territorial. Enjoy them. Yes, you're in charge. Yes, you're sort of guiding the boat, but you're getting as much crew on board as possible. I do think you do work hard, but you're asking other people. Everybody talked about commitment. And if you want commitment from other people, it's got to be from you. And so I think yes, you do get tired and you do grumble on occasions, but the fact that you're going forward and you're going to and gathering with you a group, I think can be more than encouraging. It can be truly professionally rewarding. And with it, you make a lot of friends, I think, you know, long-term friends who will advise, will help. And I think you can ring them or you can contact them in times when you feel out of your depth. And I think that's an important thing to do. We're learning, just as Minette was saying, all our professional lives. And what a wonderful thing. And as we go, it's often the very most naive of your group who will ask the question that needs to be asked. And you suddenly think, my goodness, yes, I should have thought of that. And often the answer is quite simple. So yes, I think it's that keeps you going.
Very
and
much.
Inspires you.
Mignon, do you have something to add to that question of how you look after yourself?
I agree 100% with what Liz said. I always agree with what Liz says because she's so wise and lovely. Just two things to add to that is to try and make time out for yourself somewhere along the line. And as somebody who's had my cell phone on for 24 hours a day for many, many weeks, months and years, it is important to take time out and just get a bit of time to breathe, but also to spend some time breathing within the unit. So we from time to time have a bad time in the unit where we maybe have a difficult case, or we may have a couple of deaths, which we recently had, much more than we would normally expect. And then to close the door, get some coffee and cake with your team and actually have what we call reflections. We haven't quite got it right, Minette. We still need to get our nurses in the same team, but at the moment we're doing it with junior and senior doctors and a box of tissues in the middle, and we just talk about which patient upset you most. And we don't cure anything, we don't fix anything, but sometimes just by talking about it amongst the team, you realize that everybody's human and we all kind of deal with the same issues. So I think resilience and building strength amongst yourselves is really, really important. And I think COVID has really shown us that, because we're all just exhausted a lot of the time. So taking a bit of time out to walk your cat or your dog or your budgie or whatever you need to do, spending time with your kids and just taking time out to laugh, I think is really important.
I think we've got time, unfortunately, only for one more question. We have actually come to the end of the webinar, but I think the question around selection and triage and where the patients go, who should we be admitting when they're limited beds? Should we be admitting them to only a PICU? What about putting older children in NICUs, in adult ICUs? It's a very big question, but maybe if I can pose this to Nur, who we haven't heard from, if his microphone is working, if you can just briefly give, is it not working, Ilse?
No.
Okay. Ilse, would you like to handle this one?
Yes. Yes, no, it's fine. In terms of sort of patients for PICU, so how we select patients for PICU, if we have an overload of patients as well, is to look at the benefit they can gain from being admitted to ICU. So one has to take into account the original condition, what's bringing them into ICU, what benefit can be gained by instituting various sort of treatment protocols, and then what the best prognosis would be for them as well. Yes, we have a step down sort of neonatal high care unit as well. And if we do need to utilize that space, then we would. But at the same time, one has to look at the equipment, the nursing training in that area as well, because you do not want to add pressure to an area where people do not feel sufficiently trained to deal with a pediatric case when they're used to dealing with neonatal cases as well. And for a critically ill child, you need your equipment that is appropriate for that size child as well. So that's always important to take into account. But it's always a consideration. There are always too many patients for too few beds. And how we decide about which patients to bring in is a constant, something that we constantly have to discuss with our colleagues, but also with the referring physicians as well, because we cannot put in place protocols and sort of guidelines without discussing with referring physicians, because they have to understand as well why we've chosen one patient above another patient as well. So we do try and use as many resources as we can and sort of spread it out equally amongst everybody. But we also have to look at how we could possibly negatively affect that child and of course their caregivers and the family as well.
So unfortunately, it seems like we could carry on talking for the next several hours. So watch the space, because we can do this again. And certainly next year, we will make sure that there is ample opportunity to share experiences from different regions across Africa, across the globe. We're very, very excited to be able to continue this conversation and to really carry on highlighting pediatric critical care requirements, growing pediatric critical care capacity throughout Africa. So thank you, everybody. Thank you so much to the panelists, to the presenters for really for all the attendees for your participation and for your discussion. And we look forward to seeing you the next time. And finally, last but not least, thank you to Evelyn at WIFPICS. You just see her as WIFPICS there, for really her stellar job in facilitating the process, and to Anne-Marie and to Luca for really driving this awareness week. So thank you very much, and we'll see everybody soon.
Thank you.
Bye-bye. Ciao.
Bye.
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 Ciao, ciao.